Okay, first I would like to thank Brian for inviting me to speak from this group. It's quite an honor for me, and I'm glad you brought in the therapy perspective. One of the things Brian said to me before, I asked him, who are we talking to? It's kind of a diverse group here, between surgeons, therapists, general practitioners. So he said, Rob, try to speak about what's new in the hand therapy world, so related to tendons. So I've decided to speak about what I've incorporated into my practice over the last 2 years, related to tendons and flexor tendon repairs and extensor tendon repairs. So before I go, I just want to forward this. Okay. So I have no relevant financial relationships to disclose. So first, I'm going to talk about flexion tendon rehabilitation, and then I'm going to talk about relevant motion splinting on extensor tendon repairs. Both, like I said, incorporated into my practice just recently. To start with, we're going to talk about flexor tendons. So basically, when I started about 22 years ago, and I started with, like many of you out there, using the Duran and the Kleinart, and then a combination of the Kleinart and the Duran, and then I progressed to the more active protocol of the place and hold, and used pieces of the Strickland and the Belfast active programs in my rehabilitation. Just recently, in about 2017, there's a new protocol out there called the True Active Protocol, the St. John Protocol, and this is what I've really now learned a lot from this protocol. The researchers really compared the ASHT found out what are people using out there. Everyone's using the place and hold. So these researchers came out and they compared the new St. John protocol with the popular place and hold protocol. So they found significant reductions with this new St. John protocol and active protocol, with the reduction in the rate of gapping and ruptures with zone 2 repairs. So this was a huge wow factor to me, being that I've always counted on this place and hold program as kind of the best protocol out there. And now they're telling me that there's research out there that's showing that this may not be the best thing to do. So before we, what is the St. John protocol? Before I tell you why they found that this was better, let's review what this protocol is. So Higgins and Lalonde, both from Canada, they developed the St. John's protocol, and basically the protocol starts with you wait, you elevate, and you immobilize for 3 to 5 days before active motion. Basically, their concept is that obviously we've done this with all our other programs. The swelling comes down at this time. Time to come off the pain meds. Internal bleeding should slow or stop. Collagen formation does not really start until day 3. And really, the most important is decreased friction on the repair during the active flexion, and you're less likely to rupture. So what do? They come in around day 3 to day 4, and we fabricate them a dorsal block splint with the wrist in neutral, and the MCPs at 65 to 70 degrees, and the IPs at full extension. Very similar to our other protocols. I think the major difference here is that the wrist is more in neutral position, where we tended to flex in some of the older protocols, but the wrist is more flexion. So day 3, we make this, and we begin our program. So as they come in, the first thing we do is we want to regain the passive flexion with active extension while holding the MCP in flexion. Really what this is reverse blocking, and it encourages IP joint mobility and prevents a flexion contracture of the PIP joint. I have a patient do this 10 times every awake hour. So this is very important because you're increasing the extensor tendon length, and You're keeping the joint loose for when you start your active contraction. There's not going to be any resistance there'll be less resistance on the tendon if the joint remains loose. So again, I really pushed my therapist to do this. Keep this every hour, have the patients do it every hour, because you have to keep the extensor tendon loose and the joint, you have to keep it loose. And what else this does is, it helps, you see we block the MCP and flexion, and you're gonna help decrease the point of that PIP joint contracture by isolating the tension on the PIP joint. Okay, the next thing we do at this early stage, 3 to 4 days out, we start the St. John protocol. I start gentle active flexion. It's a 1/2 modified hook fist. And what I tell my patients is really you have to initiate the motion through the DIP joint so you get the profundus to glide. So you can't just have them come down with an FDS fist. You have to really educate them. And obviously you have to educate them on, this is super gentle. You've now taken out the tightness of the extensor tendon, and they would always do this after they've got their joint loose. They're not gonna go into this first. First, they're going to loosen up their joint, loosen up the extensor tendon, and then they initiate their active, gentle, 1/2 modified hook contraction. Again, this is to really encourage active excursion of both FDS, FDP, and throughout the flexor tendon sheath. This also helps decrease inflammation and increase circulation, which helps increase the strength of the tendon. So part of my protocol is to have them do this 10 times every awake hour, right after their passive stretching and reverse blocking exercise. So I have them do that for about 2 weeks. Now, 2 weeks post-op, I'm a little more, I'm not really confident on the tendon, because the weakest part of the tendon is really 2 to 3 weeks, as we learned in the previous lectures. But here I've got the patient under my control, where I've taught them, the delicacy of the tendon. And usually they're on program, their swelling's gone down, they're a little more relaxed. So 2 weeks post-op, I fabricate an exercise hand-based splint. They call this the Manchester splint. It's really MCP's 60 to 70 degrees flexion, IP's fully extended. And I maintain the gentle tendon glide with the tenodesis effect, which we just learned about. So here you can see the patient, he goes into full wrist flexion with his fingers extended, and as he comes back, actively, now he's increased the flexion of the fingers to 1/2 full fist at 2 weeks. So it's very gentle. Again, before he starts this, we loosen up the joint, we get everything nice and supple, and then we begin our active tenodesis glides. Okay, now the protocol progresses to 4 to 5 weeks. We do this up to that point. At 4 to 5 weeks, I'm feeling a little more confident. I got through that, that third week where the tendon is a little weaker, and now I have them do the tenodesis glide to a 3/4 of a full fist with the Manchester, the little hand-based splint off. So they're going to get greater wrist flexion, and they're going to get a better tenodesis effect. At this point, we're also scar massaging, and when they're not doing the exercises, I'm definitely having them continue with their dorsal block splint. At 6 weeks, we discharge the protective dorsal block splint and begin resistive-free ADLs. So I always tell them, you're only 6 weeks, it means you're taking off the splint, but you have to be careful. We want no resistance. So whatever you can do, I always tell them no greater than lifting, the weight of a coffee cup. We start, at this point with this program, isolated FDS and FDP blocking to kind of pull through any of the adhesions that still remain. We also start gentle PIP extension stretching while limiting the tension on the flexor tendon. So I'm not going to take out the long flexor tendon, I'm going to flex the MCP, I'm going to stretch out the PIP gently and let some slack go to the DIP joint. So I'm trying to limit the force on the flexor tendon, the long flexor tendon, but try to get that resolve that PIP contraction that tends to form. At 8 weeks post-op, discharge, we're starting strengthening, return to work, and we can start some light resistant ADLs. Again, I tell them to take it easy, not go back to the gym, don't go mountain climbing, don't do anything crazy, but you can start to return to some more resistive activities. So, why does this true active motion protocol work? This is their, the researchers came out, this is what they're saying. And, I tend to agree, and I'm going to show you there are 5 reasons why they really feel this works. But, number 1, it minimizes and modifies tendon adhesion because we're doing this early active motion. It definitely increases the strength of the repair during the early remodeling phase because research has shown if you start early active muscle contraction, the tendon repair will be a little bit stronger. So we're definitely doing that, and we're starting active contraction in 3 to 5 days post-op. It definitely promotes differential gliding in the FDS and the FDP, especially when you ask the patient to really focus on initiating with DIP flexion. It helps with the PIP contractures or deformity because you're doing your early active blocking, and the early active motion will definitely help the PIP joint from contracting. And most importantly, it minimizes the work of, this is what this group has really come out, it minimizes the work of flexion, this protocol, reducing the force that can lead to gapping and rupture. So, the research, they really provided 5 reasons why to avoid the full place and hold, which I've been doing for the last 10 years, and why to perform this gentle, active 1/2 fist contraction. And the evidence here is pretty profound. So it's all come about with, and we talked about it earlier in today's lecture, about the wide awake local, the walnut procedure, where they're doing these procedures wide awake with local anesthesia and no tourniquet. So I think that because they were able to show the repair, and you're going to see some slides on this, and see how the tendon reacted to active contraction, we were able to see, the force that was on the tendon. And what they found was, that there was a much greater, their number 1 reason was that they found that there was greater force of flexion required at the last third of the full fist compared to compared to a half fist. Number 2, they found that there's greater friction on the tendon at the last third of the full fist. And number 3, if you can see in this video, I'm going to show you, we're going to watch this, that the tendon, they found when they did place and hold, they found that the tendon buckled and then jerked when they had the patient actively hold the tendon in full composite flexion, compared to a true glide when they actually had the patient come down into active composite flexion, actively. So if you look at the video here, he's passively, the tendon's buckling right there. Now he's going to, see, he just held it and then it buckles. So this is what we've been doing. We've been putting our patients in full passive flexion and asking them to hold gently. And you can see the tendon's buckling up, and now watch. He holds. Here's to show the active glide. So they're showing active smooth glide. And now he opens. This is after the repair. And now watch right here. He's going to passively bring him in. He's going to hold. And then you're going to see a buckle right there. So they're saying that buckle, that force, that jerking force, could be causing gapping or even a rupture. So I found this also very compelling. So if you do develop a gap, and here's a perfect example, there's a greater risk of pulling the repair apart on the hard edge of the A4 pulley with a full fist rather than a half fist. So they found that when the PIP was flexed over 90 degrees on the repaired tendon, there was a greater chance that it would get caught because the excursion was greater. It would pull through up to the A4 pulley. There's a hard edge on the A4 pulley, and you can see this video that Peter Amato from the Mayo Clinic provided, a lab of this. This is a lab film with this exact process, where here's a gap tendon pulling through on the hard edge of the pulley. You can see it gets caught up, and then pulls it, either further gaps the tendon or ruptures the tendon. So if you're not doing a full fist, and you're leading up to a half fist, you're less likely to get this caught up on the A4 pulley. And the 5th reason is, they basically found if you do the half fist here, they measured the excursion. They found an active half fist provides 5 to 10 millimeters of FTP excursion. So this is enough to prevent, this excursion is enough to prevent the tendon from adhering. So why not go with, if you have the joints supple, go with a half fist rather than a full fist. You have enough FTP glide to prevent the adhesion. So who's an ideal candidate for this? You know, I think, like all flexor tendon protocols, you need to have an open communication with your surgeon. I wouldn't just jump to this protocol without talking to them. I think it's important that you discuss the integrity of the tendon, how much tension's on repair. But this is something, it doesn't mean you're going to fall fully to this protocol. Just like all our protocols, we kind of combine them all. So this is something maybe if you are doing place and hold, maybe you'll start with place and hold the first couple of weeks a little, maybe you won't go full fist. Maybe you'll start with half fist place and hold till they get over, 3 weeks of healing. So maybe something we incorporate into all our protocols. But the patient, they recommended, all the research here was done with patients that have a 4 to 6 strand minimum before repair. Some doctors are doing 8. I think that would, obviously it's a stronger repair. You can do that with a 4 to 8 strand repair. The patient must have full passive range of motion prior to surgery. You don't want a tight joint going in. The patient's edema must be well controlled post-surgically. Again, more edema, more stress on that tendon, more likely to rupture or gap. And the patient obviously must be cognitively capable of understanding the exercise program, discipline regimen. A lot of these flexor tendon repairs, sometimes we get cases that this is a problem, and we obviously will adjust our protocol to the patient's cognitive ability. Okay, the next thing I want to talk about now is the extensor tendons. So this is also new to my practice over the last 2 years. We've been trying to incorporate this more and more into some of the extensor tendon injuries that we're seeing. Relative motion orthosis. So basically, this is a splint that encourages immediate full active function of the hand, unrestricted. It's really unrestricted other than the 15 to 25 degrees less extension or flexion of the metacarpal joint. And this depends if you're going to flex it or extend it on the injury. Relative motion splinting is always in relation, whenever anyone's talking about a relative motion splint, it's always in relation to the MCP joint and the adjacent fingers. So you have relative motion flexion splinting and you have relative motion extension splinting. So in clip A here, you can see this is a relative motion flexion splint of the long finger. 25 degrees more flexed than the adjacent digits, okay? What's nice about this, it preserves full interphalangeal motion and partial MCP motion joint mobility, and this minimizes the need for extensive hand therapy. So, we're having patients move full IPs and partial MCP motion with these injuries. So the concept here is, and what's important here is that when you have an injured tendon that's placed in 15 to 25 degrees less relative motion than the adjacent tendons, and here's the key, it's from a shared muscle. So as we looked at, we talked about it's an extensor or flexor, so, EDC, profundus, superficiality, these are shared muscle bellies. And that's the key. You cannot have a relative motion splint. It will not be helpful if there's not a shared muscle belly. You will experience markedly less force on the adjacent, force than the adjacent tendons. So the splint will relax the injured tendons regardless of the MCP and IP joint position. So here's an example of an extensor tendon laceration. It comes from one single muscle belly, and the relative motion splint will relax that tendon. It will put that tendon in a relaxed position regardless if the MCPs are flexed or the IP joints are flexed. I'm going to talk about extensor tendons in a minute, but the idea is that it has to be from a shared muscle belly. So the first thing I want to talk about is the relative motion. So where are we using these tendons? I skipped this, I'm sorry. Extensor tendon, we're using them really for 3 types of injuries. Extensor tendon repairs from zone 4 to zone 7, boot and ear deformities, and sagittal band ruptures. So the first thing we're going to talk about here is the extensor tendon injuries. So traditionally, all therapists here know, we did extensor tendon injuries and we've been treated with either 4 to 6 weeks of immobilization or dynamic splinting. And then over the years, we progressed to this early active short arc protocol that really requires the early active motion in the first 3 weeks, really only with the therapist. So it takes a lot of visits, takes a lot of cooperation with the patient. But we found with these protocols, we lost some flexion, we had some more joint stiffness. The dynamic splinting may or may not have provided a passive glide of the injured tendon. And again, with the short arc, we really needed compliant patients that needed to come in with a ton of visits. And now with insurance is cutting visits, it's important that we, use all our visits. As we're running out of visits, as you know, we get less and less each year. So it's important that we cut down the visits and try to get functional progress. So here's relative motion for the extensor tendon repairs. So again, zone 4 to 7 only. We put the FCP joint of the repaired tendon in 15 to 20 degrees of greater FCP extension. And we also then make a wrist splint, holding the wrist extension about 20-25 degrees. Therapy begins immediately with MCP and IP joint motion with both splints on. So we're, the prolonged extension splinting is not happening here. We've got to move the MCP, the IP joint, and then we discharge the wrist splint in about 3 weeks, and we continue with just the relative motion splint for 6 weeks. We're seeing greater joint mobility, less adhesions, and therefore less treatment time and earlier return to work and functional activity. Now we're also using this for boot and ear deformities. As we all know, the lumbricals are the principal extensors of the interphalangeal joint. The lumbrical arises from the flexor digitory and profundus tendon. And again, that comes from a single motor unit. So that's why we can use a relative motion splint. One single motor unit. So what is a boot and ear? Really, we're going to talk about that later. We talked about it a little. It's caused by a rupture of the central slip over the PIP joint with a palmar migration of the lateral bands. The lumbricals will then pull. The lumbricals pull becomes unopposed. It causes the PIP to flex and the DIP and causes DIP extension. So relative splinting for this. We splint the boot and ear digit in 15 to 25 degrees greater MCP flexion relative to the adjacent digits, and this will place laxity on the profundus tendon and relax the lumbrical. When the splint relaxes the lumbrical from its downward pull, it increases the tension on the extensor hood, encouraging dorsal repositioning. And this is regardless whether the MCPs are fully flexed or extended when we're wearing the relative motion splint. So this is not for every case of a boot and ear. This is really for the acute boot and ears. The deformities, when they come into your office, they look like the first image here, and they can be easily correctable with your hand, pushing the MCP into flexion. So if you see this is a case, it's worth a try for a relative motion flexion splint. And as you can see here is the splint pushing the MCP into greater flexion compared to the adjacent finger. Usually have them wear it for 6 weeks and assess the motion and assess how it holds. Sometimes longer. If it fails, it doesn't. It's not 100. I've done a number of these. It has not worked completely. I know we have our cases that do require surgery. Okay, the next thing where we can use relative motion splint is for sagittal band ruptures. So, sagittal band, what is the sagittal band? It's a primary stabilizer of the extensor tendon at the MCP joint. It really prevents the extensor tendon from subluxing when the MCP is flexed. Here you can see the tendon as it slips ulnarly. So, the relative motion splint, excellent for this case. Really for the acute case, so when the patient comes in and the injury is 2 to 3 weeks after the injury, the splint will centralize the EDC tendon, when the MCP is placed in 15 to 20 degrees of extension.